Dear friend, welcome once again in the live interactive teleconference of Postgraduate Diploma in Clinical Cardiology program. In these sessions, we are going to discuss about the acute coronary syndrome. And before going to the topic, there are a few important announcements I would like to make. I hope most of the centers our student has been joined as a first year PGDCC student, and especially for the first year student, I would like to request you, all of you, please work very hard through this program and come up with a good result. And we are also expecting some kind of interaction from your side, and especially for the second year student who are going to appear in the examination. I hope all of you have filled up the examination form for theory, which you need to send to register as SRN-AD. But the practical examination form, you need to submit it to your program in charge, respective to your own institution. And the examination, practical examination will be conducted only after 24 months of training. Suppose if you have started program in end of the January, then after January in the 2009 only your practical examination will be conducted. There should not be any confusion in this regards. Your theory exam, you can find it out the dates. Mostly it is the second week of the December, and I would also say best of luck to all of you. But especially the pattern of the question paper, we are having some problem, so we will definitely inform your program in charge by letter and email regarding the format of the questions paper that will be conducted for the term and examination for this PGDCC exam. So you can also interact this program by this phone and fax. Phone number already displayed by the studio, that is, I am repeating again, 011-2953-2844, and second number is 011-2953-2845, and the fax number is 011-2953-6134. Besides this also, I think all of you are having my mobile number, so you can send SMS also if you are not getting the studio line. So come up into the main topic, that is acute coronary syndrome. You know, friends, because acute coronary syndrome is the one of the major important issue of the cardiology segment, which is gaining more importance, because this is the one things by which you can really save someone's life. For that, you should know the proper management, like diagnostic criteria and signs and symptoms, everything regarding these things, because this is the one things by which sudden death due to cardiology is more prominent. And in these sessions, basically today we are having two sessions on this acute coronary syndrome. The first sessions we will mainly concentrate on this like ST elevation MI, and where we will describe about the epidemiology, the like clinical pictures, etiopathogenesis of the disease and investigations. And second component, we will try to find some kind of non-ST elevation, and mostly because management point of view, most of the ST elevation as well as non-ST elevations are same, so management component will deal both in the primarily in the next sessions. And because although there are few changes in management point of view in case of ST elevation and non-ST elevation. So today we are going mainly on this acute coronary syndrome, that is unstable angina, or ST elevation MI and non-ST elevation MI. So to discuss all these things, we are having Dr. Mitender Singh Yadav from Max Hospital, and welcome, sir. And I hope student will be really benefited by these discussions. All of you are requested to interact, because it is really very difficult to speak in front of dry camera. So we are assuming that wherever you are, at least you can inform that your presence is there. So I would like to request Dr. Singh. So please, you can start up this topic.
Good morning, everybody. As Dr. Bipul has already emphasized, that the coronary artery disease, particularly in the form of acute coronary syndrome, is the major cause of mortality and morbidity worldwide. India is not the exception. Now we are having an increased number of patients who suffer from coronary artery disease and later on acute coronary syndrome. We are going to divide the discussion in the two parts. First we'll cover, as earlier told, ST elevation acute coronary syndrome and non-ST elevation acute coronary syndrome. There is a whole spectrum of acute coronary syndrome which comprises of unstable angina, non-ST elevation myocardial infarction and ST elevation myocardial infarction. So we are going to discuss about this. As we can see from the pictures that the patient may have atherosclerotic plaques gradually increasing, and there may be a plaque rupture causing a subtotal or total occlusion of the coronary arteries, as we can see in this diagram, which will lead to subsequently either unstable angina, non-ST elevation MI or ST elevation myocardial infarction. Now the incidence, as I am describing here, is primarily derived from the data from United States. There are 1.5 million hospitalizations due to acute coronary syndrome, and more than two-thirds of them are due to unstable angina and non-ST elevation myocardial infarction. We'll go to the predisposing factors, or we can say the risk factors, conventional risk factors for acute coronary syndrome, which are primarily smoking, hypertension, dyslipidemia, metabolic syndrome, insulin resistance and diabetes, obesity, mental stress and depression. Now these have been long known, the risk factors for coronary artery disease and atherosclerosis. Now we are also focusing on few novel risk factors, which includes high sensitivity C-reactive protein, homocysteine, lipoprotein A, fibrinogen, D-dimers. Now it is very important to recognize a patient with acute coronary syndrome when the patient is presenting to the emergency department. We classically see the typical angina in the patients of acute coronary syndrome, which is defined as a pain of a cardiac character, and it includes a precipitating factor, nature of the pain and relieving factor. So if your patient is having at least 2 out of 3 classical presentations, it is referred as a typical angina. If he has got 1 out of 3, it is labeled as atypical angina, and if the patient does not have any of these symptoms, it is labeled as non-anginal chest pain. Now it is very important to differentiate between the various causes of chest discomfort, which could include acute pericarditis, pulmonary embolism, acute aortic dissection, esophageal spasms and pleuritic pain. The differentiation at presentation is primarily based on the clinical features suggesting the nature of the pain, but all these patients have to be investigated with an immediate ECG and other diagnostic modalities. Now here is the summary I am going to present to evaluate a patient who presents to emergency and where we are suspecting acute coronary syndrome. It should be classical angina at rest or less than usual activity. The nature of the pain, as I have described, should be typical, and usually it should be lasting for more than 30 minutes in case of ST elevation myocardial infarction and around 20 to 30 minutes in case of unstable angina. This pain patient describes usually as a pressing, squeezing, constricting, oppressing, retrosternal in nature, which radiates to both the sides of chest or the preferably left side of the arm and ulnar aspect of the forearm. And in some cases we may see that this may present as epigastric pain. Patients usually have other symptoms also associated with the chest discomfort. Those symptoms include profuse cold perspiration, nausea and vomiting, profound weakness, dizziness and palpitations. Patients, usually the older one or with the diabetes or hypertension, they may present with a silent acute coronary syndrome. There are certain atypical presentations of acute coronary syndrome, like classical angina without severe or prolonged pain, heart failure, atypical location of the pain, CNS manifestations, apprehension, syncope or acute indigestion. Depending upon the nature of the coronary occlusion, there may be certain ECG changes. A myocardial ischemia with subendocardial involvement will lead to transient ST depression. A transient total occlusion due to vasospasm or thrombus will lead to a transient ST elevation. On the other hand, if patient has developed acute coronary syndrome and which leads to myocardial infarction, it could be a non-QV myocardial infarction which will be seen ST depression with T-wave inversion, and a frank ST elevation myocardial infarction leading to Q-wave infarction. Now we'll focus our discussion on ST segment elevation myocardial infarction. We should know the definition of myocardial infarction. It is primarily recognized on the ECG. The definition is in interior leads more than 2 millimeters or in limb leads more than 1 millimeter ST depression in consecutive 2 leads. Like in the anterior leads V1, V2, or in the inferior leads we can say 2, 3 or 3 AVF or 2, 3 AVF. Along with this ECG changes, patient should have at least any of the following. He should have a clinical symptom of acute coronary syndrome. He should have raised markers of myocardial injury like troponins and CPK, CKMB, or there should be a new wall motion on the echo or a new perfusion defect on SPECT myocardial perfusion scan. Now physical examination of your patient once you are gone through the ECG is very important. Your patient's general appearance, whether he is having anxiety, orthopnea, altered sensorium, or he is having a rhythm disturbance in the heart, could be tachycardia, bradycardia, or other arrhythmias. A peripheral pulses should be examined for the features of peripheral arterial disease, atherosclerosis, or shock. Blood pressure measurement will tell us about the hemodynamic status, which could be hypertension or hypotension. Patient could be having hypothermia due to the shock. A respiration may show a kinestroke breathing or tachypnea. A JVP examination and chest examination could leave us with clues of congestive heart failure or right-sided myocardial infarction. Now physical examination in myocardial infarction, specifically cardiovascular examination. In auscultation, we may find that the intensity of the first and second heart sound may alter depending on the presence of a MR or a pulmonary artery hypertension. You may get a murmur of acute severe MR or ventricular septal rupture. You can also find pericardial rub in early myocardial infarction. You should look the fundus for the signs of hypertension, diabetes mellitus, or any embolism to the retinal artery. In the abdominal examination, you may find the signs of diaphragmatic irritation or hepatic congestion. Laboratory examination in the case of acute ST elevation myocardial infarction. Serum markers of cardiac damage, as we can see in this diagram, after an acute injury to the myocytes and resulting in the myocyte necrosis causes the release of substances in the serum which can be picked up and add to the diagnosis of myocardial infarction. As we can see, these include CPK, CKMB, troponin, and myoglobins. Myoglobin is early to be released and early to be disappeared. Then cardiac troponins, they come on 12 to 24 hours or maybe second day and they disappear later on. CPKMB, they have an early rise and early disappear. So from this we can diagnose as well as prognosticate the severity of myocardial infarction. Now the ECG, as we have described earlier, should fulfill the diagnostic criteria of acute ST elevation coronary syndrome, and the ECG is the only differentiating tool to define ST elevation myocardial infarction or a non-ST elevation myocardial infarction. Serial lead 12 lead standard ECG is recommended in all the patients, and the RV leads in case of inferior wall myocardial infarction are also supposed to be taken. These are the ECG sequences just to show you the pattern of evolving myocardial infarction. In case of anterior wall myocardial infarction, there is a concave upward ST segment elevation in the anterior leads and the lateral leads from V2 to V6 you can see, and there is a reciprocal ST segment depression in the inferior leads. As the time goes, myocardial infarction is evolved. There is appearance of the Q waves in the infarct-related leads and associated T wave inversion. The ECG sequences in acute inferior wall ST elevation myocardial infarction will be ST elevation in inferior leads and associated reciprocal changes in the anterior leads. Now, in the evolved phase of inferior myocardial infarction, same thing, there will be appearance of the new Q waves and T wave inversion. Now, they are the real pictures of hyperacute stage of anterior wall myocardial infarction with lateral wall extension. There is a ST segment elevation right from the beginning of V1 to V6, and ST segment elevation also in the lead 1 and AVL, and there are reciprocal ST depressions in lead 2, 3 and AVF. And now this is the ECG in the case of acute myocardial infarction of inferior wall associated with RV infarction. Apart from ST elevation in 2, 3 and AVF, we can see the ST elevation in right-sided leads, particularly leads V4R, which is diagnostic for RV infarction. So in cases of inferior wall MI, it is very important to take right ventricular leads also. Chest X-ray may suggest the signs of congestive heart failure in the setting of acute myocardial infarction and can further aid to the management. Echocardiography is particularly useful as an emergency tool, as it's a portable machine. It is very useful in cases particularly where we are having doubt about diagnosis of myocardial infarction. You got ST elevation, symptoms not fulfilling the criteria, enzymes are awaited. So with the help of echocardiography and ST elevation MI, you can determine about the arterial territory involvement. Then we can also differentiate other diagnoses like acute aortic dissection. We can also pick up early the complications of ST segment elevation myocardial infarction, primarily ventricular septal rupture, free wall rupture, or a cardiac rupture leading to acute severe mitral regurgitation. And then it will give you a fair idea about severity of regurgitations and the value of ejection fraction in those patients. Now this diagram shows that by echocardiography, if we have a hypokinesia or akinesia of a particular territory, then we can have an idea of which artery has caused myocardial infarction, as we can see the hypokinesia or akinesia and the anterolateral and septal territory will be primarily due to left anterior descending artery. Inferior wall myocardial infarction will be primarily due to a right coronary artery. Management of the patients with acute ST elevation myocardial infarction. This is a very important aspect of this topic. There are certain general points of treatment in acute myocardial infarction. Patient after diagnosis has to be immediately admitted to the acute coronary care unit. There has to be control of pain, antiplatelet agents, reperfusion therapy. It could be a thrombolysis or a primary percutaneous coronary intervention, anticoagulants, AC inhibitors or angiotensin receptor blockers, aldosterone antagonist wherever indicated, and high dose statins. Now there are other points which have to be taken care are control of blood glucose, hemodynamic monitoring, limitation of physical activity, looking for complications of ST elevation myocardial infarction and their management, and then later on early risk stratification, planning a discharge, and long-term management. Now these are very important points to be remembered, as time is muscle in case of acute coronary syndrome. You have to assess hemodynamics immediately, whether your patient is hemodynamically stable or not. he should be confined to strict bed rest with supplemental intranasal oxygen should be given. Your patient should be immediately given a 325 milligram of uncoated aspirin, which should be chewed by your patient. He should also be given a clopidogrel 300 milligram stat if not contraindicated. And your patient can be given IV beta blockers if they are not contraindicated, or they can be aided later on as a part of oral therapy. Your patient's pain management is very important, because pain is a symptom which has brought a patient to you and it leads to anxiety and diaphoresis. Usually oral nitroglycerin 0.4 milligram 2 to 3 repeated doses are given, and if they do not control the pain, IV NTG should be started. Morphine is used in the severe cases with the doses starting from 1 to 2 milligram and can gradually be increased to 2 to 4 milligrams at the difference of 5 to 10 minutes. Now, beta blockers are also useful in chest pain control, and if they are not indicated or they are having intolerance, non-hydropyridine calcium channel blockers can also be used. There is a special point to remember: you should never use non-steroidal anti-inflammatory agents or steroids in case of acute coronary syndrome, because use of these agents can lead to myocardial free wall rupture or mechanical complications of myocardial infarction. The most important part in management of ST segment elevation MI is reperfusion therapy, as it is said that the first hour is the golden hour, and if you thrombolize or you do a PCI in first hour successfully, you virtually save almost all myocardium at jeopardy.
Yeah. Sorry, sir. We are having one question from Hyderabad.
Okay.
Students are asking, how can we really localize the part of infarctions or related to the artery, which as artery part has been blocked, or like some kind of thing?
Definitely. Conventionally, we used to use ECG, because before the arrival of coronary angiography and echocardiography, ECG has been a primary tool to detect the territories involved. As I have told you, we label anterior wall myocardial infarction where we are having a ST segment elevation from V1 to V6. So if you are having an anterior wall myocardial infarction, it's a left anterior descending coronary artery which is involved. If you are having a ST segment elevation in lead 2, 3 and AVF, it is primarily due to a dominant right coronary artery. And if you are having associated right ventricular infarction, it also denotes that you are having an involved right coronary artery. And if you are having a ST segment elevation, it is supposed to be associated with a very proximal left anterior descending artery block or a left main coronary artery block. So ECG is also very important to give a clue, but it can be confusing in the case whether the left circumflex coronary artery is dominant or a right coronary artery is dominant.
Yeah. Before proceeding the things, actually one question was having in I was having in my mind, but one student from Calcutta was asking the same questions. There is a difference between ST elevation and non-ST elevation. So what could be the main root, means what kind of pathology is causing the ST elevation changes and what kind of pathology is causing non-ST elevation? Means, is there any pathological changes?
Definitely.
So this is what our student...
Electrocardiographically, as we say ST segment elevation myocardial infarction, it means the whole thickness of the myocardium, or we call it transmural myocardial infarction, which leads to the deviation of ST segment and it leads to ST elevation myocardial infarction. But if you are having a predominantly subendocardial ischemia, it leads to non-ST elevation myocardial infarction. But the rare cases of non-ST elevation myocardial infarction can also lead to a Q-wave infarction later on.
No, sir. Can it be said in the other ways, like if it is complete blockage of the artery, then it is probability
Definitely,
of
as we went to the spectrum of acute coronary syndrome, the severity of the blockage we can say is in terms of unstable angina, non-ST elevation MI, acute ST elevation MI. If there is a subtotal occlusion,
then probability of non-ST elevation,
as we are going to discuss the non-ST elevation MI in the second part, we are going to discuss that if you are having a subtotal occlusion or you are having occlusion of artery which has got rich collaterals, or you are having a secondary angina or something, when there is a partial damage to the myocardium, not the total damage and total infarct, it will lead to non-ST elevation myocardial infarction, but there is loss of myocytes which will lead to the change of ECG and the elevation in the serum enzymes, which are the primary tool to detect the non-ST elevation myocardial infarction.
Yeah. Thank you. I think our student must be understand the explanation made by Dr. Singh.
Now, as I was talking about reperfusion therapy, the first R is the golden hour. Golden hour means you can save the maximum of myocardium with the reperfusion therapy within first hours. And the trials have showed that within first 3 hours, either you do a thrombolysis with the streptokinase or other agents, or you go for a primary percutaneous coronary intervention, the results are same. This is the importance of the timing. This is a very important diagram I would like to show you. As we
Can
go
we have
for
a slide, please? Yeah, thank you.
as we do a thrombolysis or a primary PCI in first hour, we can save almost 60 to 65% of the patients. And as we gradually delay the treatment of ST elevation myocardial infarction, the less benefit is gained. So for a thrombolysis, initial 6 hours are very vital, but the improvements with the primary angioplasty are seen over next 12 hours also. Now it is very important to choose a reperfusion therapy in ST elevation myocardial infarction. Assessment for the reperfusion therapy depends on the multiple factors, primarily its time. If your patient has reached within time to you and you have got a availability of a proper cath lab with the experts who can perform a primary coronary angioplasty, it is the preferred therapy. But if you think that there is going to be any delay in the treatment, the time is less when the patient has presented to you, the thrombolysis is the preferred therapy in those patients. So it's not like if you cannot do a primary angioplasty, you cannot help your patients. Most of our patients live in the remote area and everybody doesn't have a availability of a primary PCI. So if we can thrombolyze our patient with thrombolytic agents in first 3 hours, the results are comparable. So no need to just stuck with the primary angioplasty if it is not available. It unnecessarily delay to the cath labs and leading to more and more extensive infarction will lead to a poor outcome in the patient. Now there are certain points of thrombolysis, as it's the mainstay of medical reperfusion in the myocardial infarction. It is generally preferred if the presentation is early, if invasive strategy is not the option and there is a delay in the invasive strategy. A primary PCI is preferred if a skilled PCI lab is available. Their patient is on the high risk of ST elevation myocardial infarction due to cardiogenic shock or Caleb's class 3 or more. And there are contraindications to fibrinolytic therapy if there is a late presentation or there is a doubt about the ST segment elevation myocardial infarction.
Yeah, sorry sir, just interruption again. One student want to ask, like actually he want to ask about the troponin enzyme. Like troponin enzymes or CKMB, which one is more important in case of acute coronary syndrome? And if it is troponin, then it is or I type or T type, which one is means given importance in which part? This is what he wants to know.
See, you cannot grade 1 and 2 agents or troponin or CPK or CKMB.
Okay.
If the patient is presenting to you with a typical chest pain, ST segment elevation, you may not have high values of troponin that time, because usually it may take a time to rise. It may take 12 hours to 24 hours. In that particular period, your CPK and CKMB are more important. But as the troponins are more cardiospecific, and particularly troponin I, it is the preferred agent.
Okay.
And nowadays, there are sensitive assays to just detect the minor elevations of troponins. So it is now replacing the CPK and CKMB also in the cases of reinfarctions. So there are demerits and merits of both the cardiac markers.
Yeah.
These are the various agents used for the pharmacological reperfusion. Most commonly used in our setup is streptokinase, then there is alteplase, reteplase, and TPA. The standard dose of streptokinase is 1.5 million unit given in initial 30 to 60 minutes. And no bolus dose is required, but you have to look for allergic reactions and hypotension. If we compare the 90-minute patency rate, the streptokinase has got around 50% 90-minute patency rate and around 75% 90-minute patency rate in all other agents. There are certain contraindications which have to be remembered before we start reperfusion.
May I ask one question? Like as you mentioned, the patency rate means how we will really ensure that really after streptokinase these arteries are opening.
Patency rate, you can say, is a term. There have been certain studies. You have given a streptokinase, you have given alteplase, you have given reteplase to the patients, and an angiography, diagnostic angiography was performed later on. So, how many patients have been found to have an open artery?
Yeah.
And apart from open artery, a TIMI grade 3 flow. As you must be aware of the TIMI grade 3 flow, it's like a flow in the normal coronary artery.
Yeah.
So, it is the efficacy of the different agents which leads to the clot dissolving and restoration of the normal flow in the coronary arteries.
No, sir. Actually, my question was different. Means when we are giving drug like streptokinase, and means how we will ensure there's really arteries opening up. Till how many hours or how many
Definitely
minutes?
you are not going to have, this is the theoretical data regarding the particular agents, but clinically there are certain features. We can know whether our patient
how we will monitor that it is
has
improving.
gone through a successful thrombolysis. If you start thrombolysis and your patient start developing reperfusion arrhythmias, it could be simply sinus bradycardia, it could be accelerated idioventricular rhythm, or we call it slow ventricular tachycardia if your patient's pain is decreased, and we monitor the STK score. So if the ST segment elevation is subsiding, these are the features where we know our thrombolytic therapy has been successful.
Yeah, thank you, sir.
Now certain contraindications have to be remembered before we start thrombolytic therapy. Any prior intracranial hemorrhage, any known structural cerebrovascular lesion, any malignant intracranial neoplasm, ischemic stroke within 3 months, except acute ischemic stroke within 3 hours. A patient is having suspected aortic dissection.
Hello?
There is a call from Chennai.
Yeah, Chennai, please. Please ask your questions. What is your questions?
Just want to tell that we are present here.
Pardon? May I ask you a question?
We are attending your conference. We just want to inform you.
No, we are not getting. Can you ask? Hello? Actually, I am not getting. Did you get the question?
No, I could not get it.
Please. Oh, thank you very much. We are really very happy that you are attending this conference. I think you must be benefited by these discussions. Yeah, thank you very much.
So apart from intracranial conditions, ischemic stroke within first 3 hours are not contraindications, but if there are ischemic strokes in past 3 months, they are contraindications. Suspected aortic dissection, active bleeding or bleeding diastasis. See, the menses is not a contraindication for thrombolytic therapy if there has been a significant clawed head trauma within 3 months. Now there are certain relative contraindications which depends on the patient's clinical condition. If you think that the thrombolytic therapy is going to help them, you can consider the patient for thrombolysis. But if you think that your patient may be adversely affected by thrombolytic agents, in particular these conditions, thrombolysis should be avoided. Now apart from thrombolysis, a medical therapy has to be started in patients of ST segment elevation MI. And it is very important and indicated in all the patients whether they receive reperfusion therapy or not due to any reason. Now medical therapy comprises of anticoagulant regime. It could be any of the followings. It could be either a low molecular weight heparin, fondaparinux or unfractioned heparin.
Yeah, sir, there is two questions from student. I think that need to be addressed.
Okay.
I think one student want to ask what about the GP2B3A, that what is the rule about that drug particularly in the management of that ST elevation MI. And one student wants to ask, actually she didn't write the questions properly. Dr. Rupa wanted to know what about the new onset of along with the MI, whether we should means thrombolyze or not.
I think there are certain questions in between, but definitely I'll answer them. I had covered them on the later part of the discussion. GP2B3A inhibitors are usually not recommended for each and every patient. There are certain varieties of GP2B3A inhibitors. If you are planning an early intervention in your patients, you are considering primary angioplasty in your patient, GP2B3A inhibitors have to be started as a bolus dose and have to be continued at least 24 hours after a coronary intervention. And second question was about a new onset LBBB. I just wanted to emphasize that by definition it does not fulfill the criteria of ST segment elevation myocardial infarction. But if you think that your patient's presentation is very typical, your patient has got a chest pain which is severe enough, which is having a rise in the enzymes, or enzymes could be abated. But if you see that the LBBB present in your patient's ECG, if it is new onset, it has to be treated in all forms like a ST segment elevation myocardial infarction.
Yeah, thank you very much, sir. One more information I would like to give you is 8 students in Ranchi, they are actually seeing our program, and they are just welcoming you, and they are benefited by your discussions. Thank you to all of you. Please, sir, we can continue in our discussion.
And now I would like to go slightly into the detail of anticoagulant regime. Conventionally, we used to give unfractioned heparin, usually in the dose of 60 milligram per kg stat, not exceeding 60 units per kg, not exceeding 4,000 units total dose. And then we have to continue with the 12 unit per hour, and we have to monitor APTT, and then we have to adjust the dose. But now the preferred therapy has been in the form of low molecular weight heparin, particularly enoxaparin. It's easy to administer. You can give subcutaneous doses twice a day. And then now a new agent has been approved in the acute coronary syndrome, that is fondaparinux. Fondaparinux is particularly preferred in the patients where you are suspecting high risk of bleeding. In those patients, and particularly with a mild renal impairment, you can say a serum creatinine level up to 3 milligrams, you can use fondaparinux. And most benefit by anticoagulant agents is seen in first 24 hours. But due to immobilization, due to associated high risk for deep vein thrombosis or intracardiac thrombosis or a cerebrovascular episode, we usually prolong the anticoagulation therapy for the index hospitalization, which could be 5 to 7 days. Now, statins are not just a normal lipid lowering agent, particularly when we talk about acute coronary syndrome. High dose of statin, usually it's recommended comparing the doses 80 milligrams of atorvastatin. But we have seen our patients usually don't tolerate the higher doses of statins, and they are having a low HDL along with low LDL. So we prefer a dose of 40 milligram, but the standard recommendation is 80 milligram of atorvastatin or equivalent statin should be given at the first contact to the patients of acute coronary syndrome. Their effects in the acute coronary syndrome are primarily due to their pleiotropic effect and reducing inflammation at the plaque, preventing the re-rupture of the plaque, and these effects are most beneficial when you give high dose of statins. Now, patients requires continuous hemodynamic monitoring, as your patient may be having associated arrhythmias. Your patient could be having a hypovolumic cardiogenic shock. It could be having mechanical complications of the acute MI. It could be septal rupture, could be acute mitral regurgitation, could be severe left ventricular dysfunction itself. It could be right ventricular failure, which will present as a hypotension. And now in these selected cases, we have to do afterload reduction with a kind of vasodilator therapy. We may require inotropic agent. We may require a beta blocker therapy, or beta blocker therapy has to be readjusted or reduced. We may require a temporary pacing in the cases of complete heart block or other conditions. We may require a support of intra-aortic balloon counter pulsation, or we may require a mechanical ventilation if there is a respiratory pump failure in these patients. Particularly important complications are hypotension, LV failure, and cardiogenic shock. In these particular patients, the hemodynamic monitoring can be done in the terms of inserting a central venous line, putting an intra-aortic balloon pump, monitoring their blood pressure with the use of intra-arterial line. Now we have to look for cardiac arrhythmias during acute myocardial infarction. Most of our patients present with the sinus tachycardia due to the pain, due to the anxiety, but the patients, particularly with the inferior wall MI and increased vagal tone, can present with a sinus bradycardia or a complete heart block. Patient may present with a cardiac arrest or may present with a ventricular tachycardia and ventricular fibrillation, and a primary ventricular fibrillation has to be reverted as soon as possible because it is fatal if it is not treated within seconds. Your patients, as we have told earlier, may have an accelerated idioventricular rhythm, particularly in the setting of reperfusion therapy. Now, there are certain mechanical complications of acute myocardial infarction. If your patient on a second day or third day of myocardial infarction develops sudden hypotension, sudden shock, which is not responding to the routine support therapy of inotropes, and you find on your clinical examination that your patient has developed a new murmur, like a patient is having a loud pansystolic murmur, you should suspect acute severe mitral regurgitation, you should suspect acute ventricular septal rupture. If your patient develops all of sudden signs and symptoms of pericardial tamponade, you should think of it either a massive pericardial effusion secondary to pericarditis and antithrombotic agents, or your patient has developed a free wall rupture which is causing a rapidly deteriorating cardiac tamponade. And as I have told about the papillary muscle rupture, which will lead to acute severe mitral regurgitation. Now, apart from the routine treatment of myocardial infarction, you are suspecting a mechanical complication of myocardial infarction. You should early detect them on echocardiography, and those are the patients who have to be considered for acute surgical correction with a revascularization therapy. There is no time in waiting and watching about these patients. If you don't treat them surgically, they are going to have a mortality rate of around 70 to 90%. If you treat them surgically, still the mortality rate is higher. But if you can do that, you can save half of your patients. Now here is an example of a repair of acute severe mitral regurgitation. You just fix the AML and PML here, or if you are having a ruptured cardi, you can correct surgically in these patients. Now there are certain other complications we have to look for in patients of acute STEMI. On a day-to-day examination, that's why once you have made a diagnosis of acute ST elevation myocardial infarction, you have to evaluate periodically your patient, because apart from the improvement, you are also looking for the late complications of ST elevation myocardial infarction. Your patient may have a recurrent ischemia, it may have a pericarditis and pericardial rub. Patient may develop early Dressler syndrome, may develop a venous thrombosis or a pulmonary embolism, or may develop LV aneurysm and thrombus. Now here comes the secondary prevention and long-term management.
Yeah, I think, sir, we should stop here because our studio is already given indications.
Okay.
And we can meet after 15 minutes break.
Okay.
And all the students sitting here in our studio, I would like to say welcome to all of you. And our students sitting across the India, all of you are requested to ask questions or interact with the experts during these sessions. And after 15 minutes break, we will again meet in this studio, continuing this topic. Because it is already 45 minutes, so we'll stop here. So thank you very much to all of you.